Hey YouTube, how you guys doing? Okay, so today's video is gonna be on documentation, specifically, of course, for long-term care. And documentation is basically for to track a resident's care and status, and it's also there as a tool for lawyers as well. And when you think about a lawyer, you always think about the one who's trying to find you guilty, but it's also there for the ones that are trying to defend you, okay? So in nursing, you need to make sure your documentation is thorough, and you need to write every single sentence as if a lawyer is gonna look at it and pick it apart, basically. So this video is gonna have 4 tips on your documentation, and also I'm gonna include real life examples from this one YouTube video, which you'll see. So tip number 1 is to document all behaviors that deviate from what should be. For example, say a patient is refusing a shower all the time and they refuse care all the other days, and they just always look messy, or the word is unkempt. Those patients need documentation as soon as they get admitted, and you see that, you need to document it. Patient refused care, CNA reports, patient refused care, or if he or she refused care for you, you can write that they actually refused care because you actually saw it with your eyes. What else? That's like a good example right there, like refusing care, because then they're gonna go out to a doctor's, or the family who hasn't seen them in a while is gonna come in and be like, why does my family member, or the hospital is gonna be like, why does my patient look like this? Like, what are you guys doing? And then you can respond with, yes, this patient has a long history of refusing care for us. We try our best, but they just won't let us take care of them in that way. And then when it's documented, it's care planned. Like, that's what your unit manager is making sure is being done. Once things are being documented and reported to them, now they have to care plan it, because it's officially a behavior. It's not like a 1 or 2 time thing. So then once it's care planned, the family comes in and they have care plan meetings. So when someone says it's care planned, that entails documentation in nurses' notes. Then it entails documentation in the care plan. Once it's in the care plan, the family is aware. So like, that will protect you. So when the family comes in and says, oh, they look like this, and you guys already know about this, we're trying our best. If you want to help to be involved in their care, that would be great, you know? Like, you could suggest things, and then if you do suggest things, you need to document that you suggested that to the family, and did they refuse or did they not refuse? All that documentation will work to protect you. And that's a major function of documentation, is to protect you. So another thing that you need to document, which is kind of like that behavior, is when a patient is doing something and then they need to be educated on what they're doing. For example, say a patient doesn't appear to be in too bad of a level of pain, and they are constantly around the clock requesting narcotics, and you're looking in the narcotic book and it's like, oxy, 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 oxy every 4 hours, then you can educate that patient on, look, this is a risk to you in the following ways. If there's other ways we can address your pain that you will accept, we would be willing to talk to you about that. So if you say that to your patient, you need to document it. Because if they say, oh, no, I just want my oxy, then you say that they refused alternative forms of pain management, which were offered. Another thing is smoking. You encourage them to stop smoking. You say, look, we can do nicotine patches, we can do nicotine gum. If they refuse and continue to smoke, despite having a diagnosis of COPD, asthma, whatever it may be, that needs to be documented. So if their condition deteriorates, they choose to go that route, which is sad, but we need to document when patients choose to go the wrong route. So regarding behaviors, I wanted to show you guys a video of a family member who was very upset about one of her mom's behavior. Okay, so I'm gonna show you that right now.
The final straw.
I walked into her room one afternoon and found her soaking wet, with her underwear around her ankles, lying in her bed, soaking wet. Now, why? That's finished me. That's what got me to buy the camera. They tried to insinuate she did it to herself. This woman could not roll her underwear down around her ankles.
Janet was so outraged, she went out and purchased a hidden camera. It cost her $700.
I place it here like this between two photographs.
That clip showed you a family member that was very upset about the fact that she came in and her mother, who she loved very much, was lying in a bed which was soaking wet with urine, and her underwear was on her ankles. Now, the documentary doesn't go into what really was documented on this patient's behavior, but let's hypothetically say that patient has done that. You could see how if that daughter had known, oh, my mom already does this all the time, she would be working with the staff, because obviously that daughter is very involved in her mother's care. So that's just an example of how a family member will be, and that is what you will encounter, and you need to be proactive to diffuse that situation before it even starts. So now we're gonna get into tip number 2. Document actual things only. You can't say, I'm gonna use this example. You can't say for a new admission, let's say, or a patient who has a room change, you cannot say patient adjusting well. But when you think about that, that's an opinion. That's you as the nurse saying that patient is doing good. But that's not enough in nursing. Because when you think of a lawyer, they're gonna, if you're ever sitting in court or if you're ever sitting in a deposition, they're gonna ask you, why did you write this? But you want your documentation to answer all the questions. So you sit there in court and say, like my documentation says, blah, blah, blah. So back to this example, patient adjusting well to long-term care placement. Here's the rest of it. As evidenced by patient states, I like it. You could say patient shows no signs, has no complaints pertaining to living situation. Patient appears to be pleasant. Opinion as evidenced by. Patient smiles often. patient is socializing in center, participating in activities, compliant with care, participating in physical therapy, occupational therapy. Like, if you say all that, a lawyer can't pick your sentence apart and say, well, what made you say that? Because you have to think about, once I leave, this patient could become sad. Something could happen, and if the patient could become sad, but you have to state your case like, no, the patient was adjusting well. I didn't see any signs of any depression related to long-term care placement, because long-term care placement is a huge adjustment. They go from all freedom in the world to a totally structured environment. It's a total upheaval in your life. So that should be something on any new admission, it would be addressed. And if they're coming from another facility, how are they adjusting to this one? Also, factual documentation has another aspect besides just not being opinionated. And I'm gonna show you an example before I get into it on the same daughter regarding her mother's care. So let's look at that clip now.
So outraged, she went out and purchased a hidden camera. It cost her $700.
I place it here like
Yes,
this.
they
between
can
two
do that.
Okay, so now this is the worker who's obviously getting the bed ready. And she's obviously, I guess, thinking, how am I going to get her into bed?
Janet's giving us a play-by-play of this disturbing video she captured with her hidden camera that she placed inside her mother's room.
So she leans her up against the bed here.
Which is
trying-
fine.
And puts her arm against her there to try and hold her up. My mother cannot support her own weight, and she crashes to the
The
floor.
CNA probably didn't know the
89-year-old Jean Holden
patient.
falls
Tried
hard.
to stand her
and then
up.
watch what her personal support worker does next. She picks up poor
Yo.
Jean Holden like a rag doll.
I'm not even
Just
getting
tosses
into
her
all
on the bed.
this.
She then continues to get Jean ready for bed like nothing happened.
This is the part that gets me. See, she's looking at the door.
Oh my
God. I wanted to... I wanted to crucify this woman.
There is a lot more activity on the tape, but according to Janet, it takes 38 minutes before the registered nurse on duty comes in the room.
Yeah.
Why did
that's
she then
horrible.
proceed to get her ready for bed? She didn't call anybody in at that point. I have to presume my mother was unresponsive. That's why she called. This is the RN.
Janet says this video of
This
her
is the
mother
part I'm
is
talking
very
about.
important because had she not had it, this is what the nursing home wanted her to believe.
They left a message on my machine. Your mother has fallen. Please call us. The girl said, oh yes, the personal support worker. Your mother was in her wheelchair when she went to the bathroom to get a face cloth. In that time, that 20 seconds she was away, your mother fell out of her wheelchair.
The very next day, Janet confronted the home with her video.
I said, I understand my mother's fall was from falling out of her wheelchair while the nurse got her a face cloth. Yes. I said, well, not so. I have it on camera. And she just looked at me like deer in headlights.
And
I
the
bet.
representative she spoke to was furious about the camera.
They treated me like I was the criminal.
In that clip, I'm not going to get into how that fall was handled. All I'm going to get into is the daughter was told by the nurse, your mom was in her wheelchair. The CNA left her for 20 seconds to go get a washcloth. The CNA came back to your mother and she had fallen. Okay, one thing is wrong with that. And the nurse said what happened as if she was there. What the nurse should say in that situation where CNA is with, or physical therapy or whoever is with a patient and they fall. Family member, anybody who's with a patient and they fall. The nurse would document CNA reports, blah, blah, blah. And then when the family comes to you, or the DLN comes to you, or me, or you, you're gonna say, the CNA reported that this, and this happened, and this is my assessment of the patient after the fact. Okay? That's all you have to do, because you can't say what happened if you weren't there. The only person who can say what happened is the person who was actually there. Okay? So you only say what was reported to you, and then you go and assess the patient. Do they have bruising, or do they have range of motion, blah, blah, blah. Okay, so the other thing that does is saying, when you say so-and-so reports this, it takes it off of you and puts it on that person. So whoever is looking into the fall has to go to that person. If they want to know about after the fall, now they can talk to the nurse who was on duty. Now they can talk to that nurse and say, look, after that fall, did she appear like this, or did she look like that? And your documentation should speak for itself, and there shouldn't be holes, and they shouldn't be asking you any questions. If they have questions for you, that means your documentation has holes. So be thorough and be factual, okay? Tip number 3 is, when documenting on meds, have your drug book on hand. There is a lot to documenting on meds. There's little things that you need to look for, and if they do have those symptoms related to a new medication that was just started, then the doctor needs to be notified, and then it's up to the doctor to decide, is this worth continuing medications? The other thing that you'll find with medications is, and with being a nurse in general, is doctors aren't perfect. Nurse practitioners aren't perfect. Say a patient starts on glipizide or Depakote, and you look in their chart and in their orders, or in the e-chart, whatever, and they have no hemoglobin A1C ordered, nothing on record, or they have no Depakote level ordered for a follow-up to the Depakote being started, that would be something you need to tell your healthcare provider for your patient, because they might forget to order it, or somebody might have forgot to order it, whatever. So have your drug book so you know what to be looking for, and that's basically it with that tip. Tip number 4 is a real easy one. It's just be careful with abbreviations. Be careful with abbreviations, because some abbreviations, although they are established in the healthcare field, they aren't common. Maybe your state or your group of facilities, like if you're in like a chain, they might have their own abbreviations that they approve. Okay, so just be careful with that. If like, don't use anything that you didn't even know what it was, and just to be creative, like, just keep it to regular old abbreviations, okay, that are used all the time, like SP, status post, or MS is mental status. Like, that makes your documentation go quicker. AAAO, that kind of thing. That is very common abbreviations right there. You're never gonna run into any issues, and you're not gonna get any phone calls like, please don't use this abbreviation, or blah blah blah. So guys, that's basically it on documentation. If you have any questions or comments, please leave them in the comment section. If you like this video, please subscribe. I would really appreciate it. And if you watched this long, I thank you so much. And that is it. I'll talk to you guys soon, okay? Bye.